particularly for advanced lung cancer patients, I think PD-L1 testing should be performed. One can argue whether or not on the lower stage patients it should be done up front or not. We tend to do it again for a variety of reasons, but I certainly think that every advanced lung cancer patient, at least in the non-small cell camp, should be tested. The advantages are you then at least provide an opportunity for an additional or a separate or primary new therapy that you wouldn't have unless you tested the patient. I think that you have to recognize that the immunotherapies, the PD-L1 therapies, do have side effects, and some of those side effects can be quite serious. So I think the more information that we have up front, the better. One can certainly go ahead and offer the drug to the patients, but if it were me, I would want to know what my status is before I decided whether or not I was going to take the therapy. So again, there's advantages in that it provides information. It also provides the information on patients who may not be eligible for the drug.
We're also testing all patients for PD-L1 with the 22C3 assay, and that's the assay that's tied in with the pembrolizumab. The reason that we do that is we had randomized phase 3 data this year that showed that for patients that had a greater than 50% PD-L1 level by that particular test, the 22C3 assay, that they actually did better if we started them with pembrolizumab versus chemotherapy. But that's in the context of patients who did not have EGFR and did not have ALK. So it's really important to not just test for PD-L1, but to also test for the molecular drivers, especially EGFR and ALK. If EGFR and ALK are found, we'll use that as our primary treatment plan to go after that, and then bring in that PD-L1 testing later, but generally, or the treatment later. The PD-L1 testing, though, upfront for all patients. If they've already had chemotherapy, we're not always testing. We will sometimes to get a gauge of how likely they are to benefit, especially if it's someone who we think might be at higher risk, but in general, it's at point of diagnosis.
There's growing evidence that PD-L1 testing and PD-L1 results are very important in the management of lung cancer patients, the non-small cell lung cancer patients. I think that, and so I think that's one of the reasons to argue for upfront testing for PD-L1 in all new lung adenocarcinomas and squamous cell carcinomas. There's not only evidence that it's effective as a second-line therapy, but there's recent published data establishing it as a very good option as a first-line therapeutic intervention. And I think that more and more we're looking at now evidence or trials that are combining PD-L1 with conventional chemotherapy. So there's all kinds of different avenues that are going to be available for patients. But that first requires that we know what their PD-L1 status is.